Hello, everyone. I'm excited to start this training on determination of death slash withholding resuscitation. So I know that historically or in the past, we've had a few issues with not having a paramedic available, and that essentially forced our EMTs and AEMTs to initiate resuscitation on someone who had obvious signs of death. So now we have protocol criteria for EMT and AEMT withholding of resuscitation, and that's what we're going to cover today. So, in the past, a long time ago, in George Washington's time, there were a lot of valid concerns about being buried alive because it was not uncommon for a doctor or anyone to say, hey, they're dead, we need to bury them, and then they wake up days later. In fact, there was a very common phobia, probably more common than it is today. I'm just theorizing here, because when someone died, they would actually tie a string to them, and then that string would be tied to a bell. And then if the bell started ringing, they would say, "Oh, that person isn't dead." There's an interesting story about Sipho. I don't know how you pronounce his name. I'm not even going to try to pronounce his last name. Where he and his girlfriend or wife were involved in an accident, and he was buried, and he arose from the grave, so to speak, and she did not believe that it was really him, and thought that he was a zombie. Okay, so what is determination of death? First of all, there's a lot of different terms that we're going to be talking about. We're going to be talking about obvious signs of death, injuries compatible with life, termination or resuscitation, and things like that. Well, I'll tell you, determination of death, all right, is when you arrive on scene and determine that that patient has no signs of life or signs of death, and they have obvious signs of death. So they have to actually be dead and then have those signs of irreversible death. So, to reiterate, no signs of life. So, absence of vital signs, and then those obvious signs of death that you all are already probably familiar with, or injuries incompatible with life. Now, in our traumatic arrest protocol, we do have criteria where you can withhold resuscitation on a patient who has signs of death or absent vital signs, um, who does not have either obvious signs of death or injuries compatible with life. And we'll talk about that, but that's only for paramedic providers because they have to be able to determine asystole. So the first step is to determine that all the signs of death are present. So, what are all the signs of death? Now, remember, don't get confused with terminology. All right, we're not talking about obvious signs of death. We're talking about, we're not talking about signs of irreversible death here. We're talking about just signs that that person is dead. They have to be unresponsive. All right, not responding. They have to be apneic, can't be breathing, pulseless. All right, no pulse at the carotid site, and then bilaterally fixed and dilated pupils. All right. Now, pupillary assessment can be difficult, especially if the patient is not recently passed, because the pupils can take on a certain haze. But what is, I think, most important here is the assessment of the patient. EMS providers get into a lot of trouble when they show up on scene. Law enforcement or the fire department or anyone for that matter walks up and says, they're dead, they're gone, they're obviously dead. And then they don't perform a proper assessment and come to find out that person was not obviously dead. So vital signs are vital. Make contact with the patient, touch them, palpate a pulse, auscultate. Use your stethoscope. Auscultate for heart sounds, heart tones. Auscultate for respirations, even if it doesn't look like the chest wall's moving. Expose the chest, look at the chest, and listen for any breath sounds. All right. So once you have completed step one, which was evaluated to see if there are no signs of life, then you move on to step two, which is to look for obvious signs of death. So, obvious signs of death, what we consider obvious signs of death is rigor mortis, lividity or venous pooling, and or injuries that are incompatible with life. Now, there is a spectrum of how people can determine how long somebody has been dead. Usually at the time of death, the temperature is 98.6, which is average. And then as time progresses, it takes a long time for the body temperature to reach ambient temperature. But usually the first thing that you'll see in the first 3 to 10 minutes is clouding of the corneal. And then usually around the 30-minute mark, you get you start getting some pallor, and then liver mortis usually sets in around about 30 minutes to 4 hours. So that's what we're looking for. One of the first signs and the most common signs, if it's been an hour, 2 hours, 3 hours, is that liver mortis or lividity. And then the rigor mortis, the stiffness, usually sets on 1 to 6 hours. So those are what we're looking for, and they have to be present to not initiate resuscitation. So here is what rigor mortis kind of looks like. It's generally considered the fourth stage of death. It can occur as soon as 4 hours. 4 hours, but it's probably important to note that it usually resolves around 8 hours at room temperature. All right, here are some more images of what that looks like, and what you'll see, the stiffening of the extremities. And it might be helpful if a person's laying in a position where their extremities aren't obviously rigored, for you to check the stiffness of those extremities. And here's what lividity or liver mortis looks like. It usually starts in 20 to 30 minutes, but you might not see it until up to 2 hours after death. Now, the size of this increases as time goes on, so you'll have these patches that are in the dependent areas of the body. So the blood generally starts to pool, and if there's any compression or pressure on an area, then you'll see kind of where that pressure was, because those areas will not be filled. So what is this knot? And I know you might be thinking that there's a fine line between modeling and lividity, but the protocol, and everyone always says, if there's any doubt, any reservation, any uncertainty, to initiate resuscitation. And what I'm going to tell you is, if you don't have these obvious signs of death, and they should be obvious. It's not like, oh, I'm not sure if they have these signs of death. It's, no, this patient has obvious signs of death, all right? That is the opposite of uncertainty. It is obvious. It is not modeling of the skin, because patients with pulses can have skin modeling. Okay, so you want to be sure of yourself, because here's what you don't want to happen. There are multiple multiple reports in the news and in the media of EMS providers declaring a patient dead, and then the patient actually being alive or waking up in the morgue. Now, you may have heard of the Lazarus phenomenon, and we're going to talk about that. Now, I don't think that that's what this was. I think it was, and you'll see in the video that we're about to watch, I think that it was actually the providers not performing a thorough assessment as they should, or maybe not even an assessment at all, and the patient waking up, patient actually being alive and not actually dead. All right, so I'm getting ready to play this.
Developing first at 6, 2 Clearwater Fire Rescue paramedics are out of jobs tonight, and their chief says they failed the entire community. Back in February, the medics pronounced a man dead who was actually still very much alive. There he is right there. That man is recovering tonight after spending a week in the hospital. Fox 13's Kaylee Tracy spoke with him and his family about the news nearly 3 months after the incident.
He's just about dead.
66-year-old Thomas Maxwell was close to death on February 15th, but was still alive.
They are doing CPR on him.
His daughter Phoebe did CPR while her mom called 911.
Tell me when the paramedics are there.
When the medics arrived for the cardiac arrest call,
the guy said, "Oh, you can stop doing that now." I says, "No, I'm not going to. He's not dead." He says, "Yes, and those are just, gases that the body's releasing."
According to Clearwater Fire and Rescue Chief Scott Ellers, about 1 minute after arriving on scene, medics Sebastian Pickens and Jacob Rivero pronounced Maxwell dead. Ellers says a minute after that, Pickens heard Maxwell take at least one breath, told Rivero, but they didn't do anything.
They missed the basics that they should have accomplished.
The medics said Maxwell wasn't breathing and didn't have a pulse, but despite having life-saving equipment, they didn't use any of it, Eller says.
I would like to apologize to the family for the lack of concern that these two medics displayed on that call.
The chief says a deputy later heard Maxwell breathing, found a pulse, and called for medical crews to return, and a different crew responded. Phoebe Maxwell says while she's glad the medics are fired, it doesn't erase the pain she and her family still feel.
They might be able to sleep at night, but I can't sleep at night anymore. I'm up checking on him all the time.
Maxwell was on his way to a doctor's appointment when he found out the two medics were fired, saying he agrees wholeheartedly with the decision.
Yeah, I do.
Phoebe says they both now have a hard time trusting first responders.
That's cuts to the core of my heart. Again, I've been doing this for 45 years. Our whole purpose for this, for the people that are out there, that is why we are what we are.
Kaylee Tracy, Fox 13 News.
Well, the chief says the Pinellas County Medical Director will now take.
All right, so that was a little difficult to watch, and we definitely don't want to find ourselves in that situation. So could that have been prevented? Was that a preventable occurrence or an event? I think so. I think that, if the patient did have a pulse the whole time and they had performed a proper assessment, put the patient on the monitor, look for those obvious signs of death or signs of irreversible death, then they probably would have initiated resuscitation, and the outcome would have been a lot different. So I think that the mantra of if any uncertainty exists, initiate resuscitation would have applied in this situation. What is uncertainty? Well, in this particular situation, if they had assessed the patient, I doubt they would have found actual lividity or rigor if they had placed the patient on the monitor, they probably would have seen a organized rhythm, and an organized rhythm is uncertainty. An organized rhythm in a patient who you think has obvious signs of death is definitely an uncertainty. And if you're not sure and you initiate resuscitation, and the patient, you come to find out, you start the resuscitation, and then later on you're like, I think the patient is developing lividity. Worst case scenario is that you continue resuscitation for the minimum of 20 minutes, and then it's likely that the patient's going to reach termination criteria. If you're an EMT or AEMT and no paramedics available, and the patient does not have any vital signs, but they don't have the obvious signs of death, and then you initiate resuscitation and a paramedic shows up on scene, then that paramedic will be able to terminate the resuscitation when the criteria has been met. All right, now we've been talking mostly about medical cases. So what if the patient has no sign of life, so they don't have a pulse, they're unresponsive, they have fixed and dilated pupils, and they have injuries incompatible with life? What do you do then? Well, first we need to define what injuries incompatible with life are and are not. So injuries incompatible with life is decapitation, so the severing of the head from the body. Transection of the torso, also sometimes referred to as hemicorpectomy. That is when the body is completely cut from below the shoulders, anywhere between the shoulders and above the hips, through all the major organs and the vessels. Sometimes the spinal column will still be attached. We still consider that transection of the torso. Incineration, or burned beyond all recognition, that actually has a definition as well. It's not just I look at them and I can't recognize them. It's when an estimated 90% of the body surface area has full thickness burns, okay, exhibited by ash rather than the clothing. All right. And if the skin is charred, you see no body hair. Now, you can also consider the following to be injuries incompatible with life: massive crush injury, complete exsanguination, so you have reason to suspect that the entire blood volume is gone, severe displacement of brain matter, and or evisceration of heart or lungs. These are more subjective criteria in which you're going to have to use good clinical judgment in deciding upon. And in these gray area, in these injuries incompatible with life that are kind of gray, I would consider an online med control consultation if you're not 100% certain. Now, what it is not is just a gunshot wound to the head. A gunshot wound to the head is not considered an injury incompatible with life because people can and do survive gunshot wounds to the head. So, if you're an EMT or an AEMT and you've evaluated that that patient has no signs of life, so you've checked your vitals, and you've determined that they have obvious signs of death or injuries incompatible with life, what do you do then? Well, you can't just call it. You have to do 2 more steps, all right? You place the AED on the patient. So initially, when I was considering this protocol, I looked at some other model guidelines and seen that this was included, and I thought it was a really good idea. Because if you place an AED on the patient and you hit analyze and it says shock advised, well, that would create some uncertainty. And then initially, when the state medical director was putting together protocols similar to this, he did not include this. And I said, well, I'm going to include this, and here's my rationale. It kind of encourages us to put hands on the patient to perform an assessment, and then he changed the state's protocol to include this. So you place AED on the patient, you hit analyze, and the AED advises no shock advised. At that point, you will contact Online Med Control and request that resuscitative efforts be withheld based on medical futility. Now, physicians should not ask you to provide any care that is considered medically futile. And you will need to thoroughly and elaborately explain why it would be futile for them to say, all right, I agree, any resuscitative measures would be futile. So you'd have to explain that the patient has they have no signs of life, they don't have a pulse, they have bilaterally fixed and dilated pupils, they have no spontaneous respirations, the heart tones are absent. We have placed the AED, it says no shock advised. We can't interpret the rhythm, but that's our protocol. The right thing for them to do would be to give you orders to withhold resuscitation. Now, you are not determining death. You're not declaring death. You are withholding. That is the terminology that you should use. You're withholding until the coroner or an ALS provider, such as a paramedic, gets on scene and can then confirm and declare death. Okay, they will monitor the rhythm for asystole and confirm death. Okay, so that is how that process works. Now, the paramedic determination of death is similar. It's all of the other criteria, except they don't have to put the pads on a patient and hit analyze. They can place the leads on the patient and confirm asystole in 3 separate leads. So here's kind of how it would look. No signs of life. Then you check for obvious signs of death or injuries incompatible with life. If you're EMT or AEMT, you will place the AED on the patient. Hit analyze and listen for no shock advised. If you're a paramedic, then you're going to look for asystole in 3 leads. Okay, now that you have determined death, if you're EMT, AEMT, you've called Online Med Control. If you're paramedic, you've placed the leads, and you've requested the coroner, who remains on scene. So paramedic can contact Online Med Control if they're unsure, but if you're determining for obvious signs of death and there's uncertainty, you should probably initiate resuscitation. If a paramedic determines a patient to be dead, paramedic should remain on scene unless personal safety is jeopardized until the coroner arrives, the deputy coroner, or law enforcement. So a paramedic can turn over care. Now, if the EMT withholds resuscitation because they are not declaring death, they should remain on scene and closely monitor the patient for any changes. And the rationale behind that is if the AED says no shock advised, that doesn't mean that it's asystole. It could be organized electrical activity. All right, so what we want you to do is just remain on scene. It's unlikely that it's going to be organized electrical activity if the patient truly does, and then there's no uncertainty, and the patient truly does have obvious signs of death. However, current best practice, what we think is best practice, is that you remain on scene and just closely monitor that patient. Now, obviously, if your personal safety is jeopardized, then you're going to leave the scene. All right. Documentation. So here are some things you should document. Body position and location when last discovered, the condition when last seen alive, clothing and condition of clothing, and the conditions of the location found, statements made on scene, and any unusual circumstances. We generally don't do a good job documenting these things. We're good about documenting what the obvious signs of death were and that the patient had no vital signs. Something else that I'm going to request is that you transmit all monitored data. Attach that to the patient's electronic health record.